Good evening, everyone. Let's wait some few more minutes for other registered participants to join us. Please, please, please join me. Try to mute.
Why you sensible? He please try to play smart. I have not started education. Well, then the outcome. Why it belongs. So from the Einstein is saying lower respiratory tract infection. You can a bit like this with sinuses, the larynx.
Good afternoon, everyone.
Oh, hello. Good afternoon. We are waiting some more minutes for more registered applicants to join us.
Okay.
We'll be starting the meeting by 4:10.
All right. Can I share my slides, or can someone make me a co-host so I can share my slides, if you don't mind? Okay.
Okay.
Can you see my screen?
Yes. You can see
All
it,
right.
ma.
Is it moving?
Yeah.
Okay, that's fine. So I'll wait when you're ready.
Okay.
Hello, good evening. Someone is talking on that net. I don't know who is that person.
Please, can everyone mute their mic, please? Okay. Good afternoon, my colleagues, and welcome once again to the Internal Medicine Interest Group of Nigeria Academic Series. Yesterday we had our first sections on the ECG foundations, which laid an excellent background for today's discussion. Today is particularly special for us as a group because we have a consultant, Dr. Francisca Olufumlayo Inofo, who has been a part of our journey right from the start. So we are pleased to continue this journey with the next section, which is focusing on the crucial aspect of cardiovascular medicine. So this discussion promises to enrich our knowledge, sharpen our diagnostic skills, and further strengthen our collective pursuit of excellence in internal medicine. We appreciate your presence and commitment, and we look forward to a highly engaging and impacting section today. Before we proceed, I would like to call on the Vice President of the Internal Medicine Interest Group of Nigeria to please quickly give us an opening remark.
Hello, good evening, everyone. Please, am I audible?
Yes, you can proceed.
Okay. Good evening, everyone. Good evening. On behalf of IMGN, it's my pleasure to warmly welcome. On behalf of IMGN, it is my pleasure to warmly welcome you all to the second day of IMGN online Ecg Training.
Host should mute this person now. The host should move the person. Should mute the person.
Yesterday's session was truly enlightening, and I believe we all found it to be both engaging and rewarding. I also trust that many of us have taken time out to review the slides that were shared yesterday as this will certainly better our understanding as well as our participation in today's class.
All right. Thank you so much for that. I think he probably had the network issue. Please, am I being heard? Am I audible?
Yes, we
Yes,
can
you are.
hear you.
Oh,
Yes, sir.
oh, okay. Thank you. So, as I was saying, okay. So, as I was saying that today is a particular special day for us, and I'm sure many of us who was with us when we started the Internal Medicine Interest Group of Nigeria know Dr. Francisca Olufumlayo, because she has been part of the journey. And when she was informed the other time for a section on what is internal medicine and what internal medicine entails, she graciously honored our invitation, and it is therefore a great privilege to have her back with us again today. So, Dr. Inofo Mo is a consultant cardiologist and head of the cardiology unit at the Olabisi Onabanjo University Teaching Hospital, Shagamu. She's a fellow of the National Postgraduate Medical College of Nigeria, a certified heart failure specialist, and an active member of both national and international cardiology society. Beyond her professional excellence, she's deeply committed to mentorship, outreach, and advancing cardiovascular care across sub-Saharan Africa. Um, she is a Nigerian trained as an undergraduate with MBCHB and postgraduate degree with a prestigious fellowship from the National Postgraduate Medical College of Nigeria, FMCP Cardio, in 2018. She's a full member of Nigeria Cardiac Society. She's a professional member, European Society of Cardiology. And as I said earlier, she's a certified heart failure specialist. She graduated at the second cohort of African Heart Failure course, Pan-African Society of Cardiology, PASCA. She's a certified clinical researcher with distinction, first cohort PASCA Clinical Research Task Force. She's an international member of American College of Cardiology. She's a member of Heart Failure Association of World Heart Federation, and she's a specialist in adult general cardiology with special interest in preventive cardiology, hypertension, arrhythmias, heart failure, and cardiometabolic renal disease. As a hospital consultant at the Olabisi Onabanjo University Teaching Hospital, Shagamu, she steers our cardiology team members in delivering optimal cardiac care to all sections of the hospital. She also serves as local consultant to Alpha Clinic Family Practice in Shagamu, Jollard Multi-Specialist Hospital, and Josemary Specialist Clinic, both in Lagos. Our passion and dedication to optimal specialist care knows no boundaries. She has volunteered at multiple seasonal medical outreaches, both in Nigeria and sub-Saharan Africa. Our vision is to reduce the burden of cardiovascular disease in Africa using all available resources. She's interested in continued academic and professional growth. She's an external examiner to the Babcock University Teaching Hospital, Illusion, Remo. She serves as a peer review in multiple renowned journals, head of cardiac research group, OOU Teaching Hospital. She's a site investigator in multi-center and multinational clinical research studies with some publications in renowned journals. She loves traveling, reading, speaking, and giving aids. And she's happily married with children. So we are delighted to have her speak to us today on rhythm disorders. Please join me in giving a very warm welcome to Dr. F.O. Inofomo. Please, Ma, you can proceed with your presentation.
Thank you very much for the welcome. I just want to quickly call your attention to the fact that quite a number of people are waiting in your waiting room. And I hope this will be a seamless one as we will keep admitting them. I'm going to switch on my video now, but just in case we hope that the network does not get so bad, I might have to switch it off. Thank you once again for having me. I want to thank the Internal Medicine Interest Group of Nigeria for calling me here again, though it's quite a huge task. But I see that you have quite a number of renowned cardiologists on board, and then I'm sure my colleague has done justice to the foundation. So on that, I would move to today's presentation. So this afternoon, we'll be spending maybe about an hour or more together, trying to look at what reading disorders is all about. We're going to be using the following outlines: introduction, conduction system of the heart. We need to look at it so that we understand and we do not cram. I will try as much as possible to make it simple as much as possible. So basically, if we're looking at reading discharge, reading disorders in the heart, it starts with what exactly does the heart do? So what is a rhythm? A rhythm is a strong, regular, repeated pattern of movement or sound. So when we talk about rhythm, the first thing that comes to our mind is music, right? So there's rhythm of music, there's rhythm of breath, and there's rhythm of sounds. As much as possible, what is peculiar to all this is that there is a regular and a repeated pattern. It must follow a particular way and move in a particular direction. That's what a rhythm is all about. And so generally, we have 4 types of rhythm. We have regular rhythm. We have alternating rhythm, in which, something happens this way, and every 2 minutes, it happens that same way. That's an alternating rhythm. We have a progressive rhythm, in which you will have a continuous flow of what is happening in a particular order. Okay, and then we have a flowing rhythm. All these are just semantics to help us bring to life what we are going to discuss shortly. So rhythm is also seen in all aspects of life, even in artistic life, in pumping action and all that. So which is the best organ in the body, like I always say, encompasses all of these. It is one of the special organs that makes sure that it does its work in a particular fashion. And so today we want to look at what happens if the heart does not do the normal pattern, and then what we see on ECG, since our interest is in understanding ECG and how to be able to pick those abnormal readings. Also, by way of introduction, we must understand that the heart is unique as it is. It is the one that is in charge of its own mini circuits. Unlike other organs where you probably find something else, an external force that is doing the work. The heart is such that it's the only one that is doing the work. It's the only one that is showing what is happening. Okay, so the heart has its own mini circulation and can respond to and generate an electrical impulse that creates the beating heart, contraction, and relaxation. This is achieved through specialized pacemaker cells with unique characteristics, using the sodium-potassium pump to depolarize and repolarize, resulting in an orderly pathway for electrical conduction. I am sure that we all understand what repolarization means and repolarization. That must have been taken care in our first cohort, right? I would like responses, please.
Yes, ma.
Yes, ma.
Great.
Yes,
So
ma'am.
the heart is made up of those special cells that helps it to do this conduction by its own. It doesn't wait for the hypothalamus or wait for everything still works together. But the heart has its own inherent probability to say, okay, I've reached the particular thresholds. I need to create an action potential. And so we're going to see more of that shortly. Now, the heart conducting system coordinates rhythmic contractions for efficient blood flow. And that's the reason why we have to go through this. It is all these organized patterns that helps the heart to be able to pump blood out. And that's what we call our cardiac output. And if it does this, it's able to supply every part of the body. That is the mechanical output. But there are some electrical pathways that goes into this before it's able to do that mechanical function. And that's what ECG is all about, the electrical activity of the heart. Now, this electrical activity starts with the pacemaker of the heart. The pacemaker of the heart is the SC node. You can see my pointer here. Okay, and then the SA node goes to the AV node. Those are the two nodes of the heart. SA node is located on the right side. And then from here, electrical impulses discharges from here and goes down to the AV node. From the AV node, it goes through the interventricular septum at the same time, unlike the atrium, where you have the right atrium, it goes through the backhand bundles to the left atrium before it produces which wave. Let's see if we still remember what happened yesterday. Which wave is produced when we have contractions from the SA node to the left side of the heart before it gets to the AV node? What wave is that?
P wave.
Very good. So that means we'll move faster today. So when we have contractions down to the interventricular septum, it goes to contract and involve the Purkinje fibers. It goes through the AV node to the east of bundle, and then it comes down to the Purkinje fibers. These are tiny fibers. They are the ones that are connected to the myofibrils, the basic cells that made up the heart. And then all these are synchronized together to give our atrial and the ventricular contraction. So all these together makes up the conducting system of the heart. Now, what are those network of specialized tissues that stimulates contractions? One of them is pacemaker, which is the SA node. And then we also have the modified cardiac myocytes. These are not big deal. They're just myocytes, that are basic cells that are incorporated into the AV node, the ease of bundle, the Purkinje fibers. They are all in these red tracts that you find. And then the heart can contract without any innervation. Like I said, it doesn't have to wait for any stimulus from outside. So all these myofibrils together are its own nerves, if I may put it that way for better understanding. Okay, so we move on. Now, the conduction system of the heart comprises specialized myocytes. I mentioned that, and they generate and transmit electrical impulses. Starting at the sinoatrial node, these signals pass through the AV node to the bundle of V's, to the branches, and then the Purkinje fibers. I've showed you that on the picture. Now, these modified cells lacking myofibrils trigger excitation. It's important to understand that they work at a particular cellular membrane, resting membrane potential. So once this, and which is always negative. So once this increases, that is when the action potential is produced. We need to understand some important terms even as we dive down into rhythm disorders of the heart. 4 things. Automaticity. I've explained that the heart does not wait for anybody to say it's time to pump. No, it does that by itself. So the heart, unlike skeletal muscles, has its own special automaticity. The heart's ability to spontaneously generate and initiate an electrical impulse is what we call automaticity, because I'm going to be looking at this, I'm going to be referring to these terms. That's why I'm explaining it now. It is this property that allows the normal pacemaker is the sinoatrial node, to spontaneously initiate their own impulse. Now, to understand that the SA node is the one that begins every impulse, and that is what denotes what we call a sinus rhythm. If there is an impulse, if there is any other part of the body, any other part of the heart that stimulates an electrical impulse, it might not necessarily be an abnormal rhythm, but we know that it is not coming from the original pacemaker, and something happens, which we will see in the rhythm strip of the ECG. Now, the next term is conduction. Conduction means the heart cell's ability to transmit. I'm producing an impulse, and I'm also able to conduct it. Okay, I'm able to transfer it. That's another term. The heart's ability to be able to transmit or transfer an impulse from one part of the heart, from a neighboring cell to another neighboring cell along a particular set pathway. Okay, so that's conduction. The next is contractility. In its own way of doing this in a rhythmic fashion, in a normal pattern, it contracts. The ability of the heart to receive and respond to any impulse. I'm able to push. I'm able to relax. Contractility can also be divided into depolarization and repolarization. And these impulses occurs by shortening fibers, and thereby they contract. The other term is excitability. The ability of the heart cells to react and respond to an electrical input. So all these 4 terms we should bear in mind. Now, still talking about the conduction pathway, the SA node normally generates the action potential, which is like the energy to initiate an electrical impulse. and this causes contraction. Now, this contraction happens in the right atrium, travels through the Bachmann bundles. I've explained this earlier, to the left, to excite the left atrium. So this impulse travels through an internodal pathway in the right atrium to the atrioventricular node. I have showed us this picture. So let's just have a mirror of this picture in our minds as we go on, so that I don't have to keep going back. So this is what I'm just trying to explain in words again. So now from the AV node, the impulse then travels through the bundle of E's down to the bundle branches. So through that bundle of E's, it goes to the left bundle branch, it goes to the right bundle branch. Bear that in mind. And it does that about the same time. Rapid transmissions about the same time. Remember that when it's coming from the ST node, there's a small pulse. When the heart pulses a bit to gather all the impulses from both atria to go to the AV node, what part of the ECG does that show us?
That's the downside of saying
PR interval.
Can someone hello? When the heart transmits impulses from both atrium to the AV node, there's a little bit of pause for it to gather together at the AV node junction before it goes to the bundle of E's. What does that show on ECG?
PR interval.
Great. So it is important to bring these references back to our mind, because we're going to be talking about nodal blocks and nodal. So all these pathways are important to help us to understand rhythm disorders. So that is the PR interval. And we know that once the PR interval is prolonged than normal, we begin to talk about AV blocks. So this helps us to understand physiology, to all those pathological signs we are going to be seeing on the ECG shortly. And so now, I say from the bundle of E's, it goes to excite both right bundle branch and left bundle branch. So along the line, when you see, oh, this is a rhythm strip, and they say, oh, there's a bundle branch block, you already understand that this is because from the bundle of E's, either the right side refuses to depolarize, refuses to contract the right ventricle, or it's taking a very long time for it to do so, because we say, oh, this is a right bundle branch block. Or if it occurs on the left side, we say, oh, this is a left bundle branch block. And first thing that happens on the ECG when there's either of these blocks is that your QRS complex, which is the ventricular, which is one that shows the ventricular depolarization, becomes widened more than usual. And then from there, we go to the bundle, once both bundles are excited, then they transfer impulses to Purkinje fibers, which are millions of small fibers projecting through the myocardium. And so the cycle continues over and over again. This is just giving us a diagram of what I've explained earlier on. Now, the cardiac action potential, if you put our minds back to our basic physiology, the cardiac action potential has 5 phases, and these phases are important for us. Okay, we talk about the phase 1, which is the rapid depolarization of sodium influx, and phase 0, rapid depolarization of sodium influx. Phase 1, brief initial repolarization, where there's a transient efflux of potassium. Now, it's important to understand that sodium, potassium, calcium concentration on our body goes a long way to affect the resting membrane potentials of the heart. And so sometimes when we find an abnormal reading, you see us quickly asking for what is the electrolytes of this patient. Okay, so these phases happens very rapidly, but it's important for us to understand it. So we have the phase 1, we have the phase 2, we have phase 3 and phase 4. Why this is important is that all this allows a normal reading, and we call them absolute refractive periods. So there's this period where it has gone through 0 to 4, and then it's rest before it continues again. The rest is arbitrary, a very few seconds, but it must take that rest to show that I've completed this cycle and I'm going again. Okay, now I'm mentioning this because there are some of the reading disorders that occur during this rest phase. Instead of the heart to rest, absolute refractive period, another action potential is being generated. And most of the time, this action potential is not generated from the pacemaker. So that creates an abnormal rhythm. Okay, so this is an example of, this is a graph showing 4 phases, phase 0, 1, 2, 3, 4. The plateau phase and the electrolytes are coming in and out through the sodium potassium channels. This is the typical diagram that shows the normal threshold and reduced rate. Once this is reduced, it causes a depolarization, and then the action continues. Now,
Hello, I
We
can't
can't
hear
hear you.
you.
Hello, please unmute,
I can't hear
the
you.
host, abeg. Unmute the presenter, please.
I can unmute myself. Am I audible now? Hello?
Yes,
Yeah.
yes.
Yes, ma.
Yes, ma.
Okay,
I
great.
can hear you.
Yes, ma.
I think this was just where you lost the voice, right? We can continue here.
Yes.
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 Okay, that's fine. So I'm just showing us what the normal ECG looks like, and then the fact that you have a sinus rhythm, a P wave preceding every QRS complex shows that this is coming from the SA node. Okay, and so we have a regular rhythmic pattern of P wave, QRS, T, and then it continues again. However, if there is an abnormal, this shows the absolute fractive period. If there is an abnormal generation of impulses, then something will happen here which makes it abnormal. Okay, now look at this closely. Sometimes we miss this pathology on ECG. We have put it closely with our sinus rhythm. It looks normal, right? This is what we call the nodal rhythm, in which your P wave, that means everything that has happened in the atrium, is hidden. You cannot see it. So it's either that it has occurred very sharply and is hidden within this place, or the initiation of the electrical potential is happening from the junction, that sinus pulse, from that junction of AV node. Now, in this situation, you could actually have normal heart rate, or you could have a slower heart rate. I'm going to go further on that later. Now, what are the mechanisms of cardiac arrhythmias? Reading disorders results from two major things, either abnormalities of electrical impulse generation or abnormality in the conduction. I'll go over it again. Reading disorders occur either because the heart cannot generate an impulse. Either it cannot generate it from the SA node, or is unable to generate it at all, or is only able to generate it through another pacemaker pathways. Or it's been able to generate it, but there's a problem along the line. There's a problem with the conduction, or there's a problem with both impulse generation and conduction. So any of these will cause an abnormal reading on our ECG. Now look at the common one, bradyarrhythmias. Bradyarrhythmias typically talks about disturbances from the formation of impulse. Once the formation of impulse is not from the SA node, or disturbances in the propagation at any level, it will cause a slow heart rate. And that is when the heart rate is less than 60. We all know that the normal heart rate is 60 to 100 beats per minute. So when it's less than 60 beats, we talk about bradycardia. Bradycardia is when it is occurring from the SA node, but it is just slow. Sinus bradycardia. However, there are other bradyarrhythmias that the impulse generation might be from any other part, or from any other pacemaker cells. The original pacemaker is the SA node. But like we said, that every part of the heart has its own automaticity. So if it occurs from the AV node, if it occurs along the east of bundle, it will cause a lower heart rate. And that's the first sign. So this is problem with impulse generation. The other one is tachyarrhythmias, which can be classified according to mechanism involved. Now, I said that is either problem with impulse generation or conduction problems. Most of the time, tachyarrhythmias is problems with conduction. And conduction problems can either be automaticity or triggered or re-entry. I'm going to explain that further shortly. Now, the mechanisms are generally divided into disorders of impulse formation or disorders of impulse conduction or combination of both. Now, like I said, some tachyarrhythmias can be started by one mechanism and then perpetuated by another. And that's why it's important to understand the mechanisms of arrhythmias. This is particularly true to so many other re-entrant arrhythmias, which often require an initiating premature activation resulting from some type of abnormal impulse generation. Sometimes it might even be because of an excess influx of sodium or excess efflux of potassium. You understand, that can cause a reentrant arrhythmias or an abnormal pathway. Now, this diagram is just putting it together, mechanism of arrhythmogenesis. Is either disorders with impulse generation or disorders with impulse conduction. Now, when it has to do with impulse generation, the problem is there's an abnormal automaticity. That means there's a problem with either the SA node, there's a problem with the heart initiating its automatic electrical potential, or is doing it, but it's doing it at a very fast rate or at a very low rate. Either triggered activity, fast rate, or very low rate. Something is triggering it abnormally. If it is impulse conduction can come from either a conduction block. Remember, I told about our bundle branch, or either left or right, or there's a problem with the east bundle, or it's doing it through another mechanism. Oh, one part is not working very well. I cannot afford to pause or stop at this place. I must complete the circle. And then the heart goes through a re-entry. So all this will give different forms of rhythm disorders. So what I have on this last row tells me the kind of rhythm disorders that will occur from these mechanisms. Do we understand? Are we together? I hope I've not lost you yet.
No, ma,
No,
we're
ma.
together.
Great. Now, to keep it simple, you look at this RAT, I call it RAT. So that brings to mind sharply what are the mechanisms of arrhythmia. Is either a reentrant or an automaticity problem, a problem with triggered activity. Now, disorders that occur from impulse formation, that is problem with impulse formation, is either it is abnormal automaticity or there's an abnormal triggering of the normal SA node. Now, problems with impulse formation will cause either a bradycardia or a tachycardia, or there's a discharge of an ectopic pacemaker. Somebody somewhere feels that I know more than the SA node, and then I'm going to initiate this reading. I'm going to initiate this action potential, and then it does it. So we call that an ectopic pacemaker that then takes over everything that happens in the atrium and the ventricle and takes over all the reading. Or sometimes the SA node may actually be doing its work, and then you just come as an escape. Something just triggered it or fires it abnormally, any of the other pacemaker cells, and then the pacemakers excite and is able to transmit impulse. And so we call that an escape reading or an accelerated automaticity. And this is the example of this is when we hear us talk about premature atrial complexes or premature ventricular complexes. So this is an example of impulse formation occurring from the SA node. When we have less than 60 beats per minute, like this, you have more than 5 boxes in between the RR intervals, then you have beats less than 60. That's sinus bradycardia. You can see it is actually coming from the SA node, but it is slower. While your tachycardia will be faster. We have a heart rate greater than 100. This is actually not a very nice picture. Now, abnormal automaticity can occur when cardiac cells other than the SA node spontaneously depolarize and reaches threshold prematurely, like I explained earlier on. And then this can result from enhanced automaticity. For example, there's a reduced blood flow, there's a reduced cardiac output, but the heart does not want the body to suffer in the midst of low output. So part of those myofibrils, part of those hearts goes ischemic. That means they are not better perfused, but the heart still has to do its work. So in situations like that, some other pacemaker cells are enhanced. You're trying to meet up with the body demands. Okay, so that's where you have enhanced automaticity. And this can occur in electrolyte imbalance. You have a rapid rush of potassium, or you have an hypoperfusion, which the body is trying to compensate with, or you have a suppressed normal pacemaker function. And this occur even in our elderly. It has some form of hold, or let's say elderly pacemaker. The SA node is trying hard to keep the heart functioning. So when it's suppressed, some other part will say, oh, let us help. We cannot decide not to do anything at this time. So they all help themselves and they have an enhanced automaticity, allowing a latent foci to now dominate. Now, the result is ectopic impulses that trigger premature beats, such as APCs, VPCs, or sustained arrhythmias. Now, APCs and VPCs are common rhythm disorders that occur after sinus bradycardia and sinus tachycardia because of abnormal automaticity. Now, what APC means that premature complexes occurring in the atrium. That means you have an extra P wave showing that was not properly conducted. Or VPC, ventricular premature complexes, an extra ventricular contraction that comes shortly after the QRS complexes. But you notice that that particular QRS complex is not the same size, it's not the same shape as the one that you have coming directly from the SA node. I hope to show you some of those examples as we go on. The other important mechanism of arrhythmia is the reentry. During the normal cardiac cycle, activation begins in the SA node pacemaker and continues until the entire heart is activated. However, the cardiac impulse stops propagating when all fibers are being discharged and are completely refractory. Remember, I told you there's an absolute refractive period, there's a relative refractive period. During this absolute refractive period, the cardiac impulse has no place to go. Okay, it's supposed to rest. Activation is then initiated by the next sinus impulse. However, if some itunos are present along that pathway, you understand what I mean? A group of fibers that were not activated during the initial wave of depolarization, they now suddenly recover excitability in the time when the whole short phase is supposed to be absolutely refractory, and then they begin to reactivate before the impulse dies out, before we finish QRS repolarization, and then they come in again and start some form of excitation. So these fibers may now serve as a link to re-excite areas that were just discharged and have now recovered from the initial depolarization, not allowing them to rest properly. So you see it firing. Reentry causes arrhythmias when an electrical impulse re-excites tissue that has recovered excitability, creating a self-sustaining loop. Like I mentioned, it just begins another rhythm that makes it look like a normal rhythm. So you have a self-sustaining loop of depolarization. Now, this requires a conduction pathway with either a unidirectional block and areas of slow conduction, allowing the impulse to re-enter and repeatedly activate both atria and ventricle, producing tachyarrhythmias. And that's what gives rise to atrial flutter. It is occurring at a particular pace, but it has only occurred because it has come through a re-entry conduction pathway in which it has blocked some parts. It's just following a particular channel and it's doing it at a particular pace, or it's not doing it at a particular pace, but at a slower pace, forgetting that the main pacemaker is still trying to do the normal work when it has fully repolarized. Are we together? So examples of that is what causes atrial flutter or AV nodal reentrant tachycardia or even ventricular tachycardia. I'm going to show
Sorry,
some
ma'am.
ECG patterns. Yep.
Ma'am, can you go over the reentry again?
Okay. So the reentry means that the SA node is supposed to finish from SA node to Purkinje fibers, finish from P wave to the end of QRS complex. However, there is some pathway in which the instead of them resting fully before they start again, reentry means that I call it some itunos, some part of the myocardial fibers decides to initiate another action potential. And they can do this through a particular conduction pathway. They just generate their own pathway. Still within the pacemaker cells, they have what we call a triggered activity or an automaticity. So they re-enter, instead of the thing to fully rest, they re-enter either through the AV node or through the Purkinje or fiber or somewhere. But one thing that makes them to sustain is that there will be a block. There will be kind of a block or a slow pathway along that area. So that gives them opportunity to start all over again and continue that repeated pattern, activating the atrium, the ventricles, trying to follow normal pattern. And so in that situation, you find the normal SNO trying to do the normal thing, but probably because it was too slow and this ectopic pathway has come in, they too will run the course. And so on the ECG, you have what we call an atrial flutter. You see plenty P, or you see some kind of sawtooth appearance or kind of jagas on the ECG, okay, showing that there's another re-entry potential that is trying to make the heart depolarize at a regular pattern, which is an contract or to excite all the atrial, the ventricle, like that in that pathway. So example of re-entry mechanism is you call atrial flutter, AV nodal re-entry tachycardia, or even the ventricular tachycardia. So all these mechanisms I'm trying to explain is to help us understand what happened when you begin to see the rhythm strips. Okay?
Yes, ma'am. Thank you, ma'am.
Now, this is summarizing what are those prerequisites for re-entry. There must be a substrate, that's in the presence of a joint myocardial tissue with different electrophysiological properties, conduction and refractoriness. The myocardial fibers or myocardial cells, or maybe underneath left atrium, are the ones that are supposed to do the work, that are doing it. So three of us now come together as a substrate and say, okay, we can now do what the SA node is doing. Let us start our own firing. So they have 2 or 3 tiny cells come together as myocardial tissue with different electrophysiological properties that are ready to do conduction. Remember that every small part can actually conduct because the heart has its own intrinsic ability to excite. Then there will be an area of block. This area of block can actually be a substrate, either an anatomical block, a physical block. An example of that is like maybe a previous fibrous tissue. A mark is on that heart. Or a functional, maybe this part has been ischemic before. This part of the heart has been dead before. It was not properly perfused. So it has become seemingly dead. Or both. You have both a tissue, a fibrous tissue, and a functional pathway that has not been working. So that's
Can't hear. Hello.
Hello.
Okay, so it is not me. Maybe it is the presenter. The network issue.
Okay, please just hold on. I guess she has a network. We'll reach out to her.
Okay, no problem. You are waiting.
She's having a network issue. Please just hold on a bit. She'll be back with us soon.
Okay, you anticipate.
hello. Hello,
Hello.
am I audible?
Yes, Maria.
Yes,
Yes,
ma'am.
yes, yeah.
Wow, so sorry. That was our network issues. Let me try to reshare my slides here and we'll continue. Okay, can you see my slides now? Hello?
Yes, ma'am, we can see your
Yes,
Yes,
ma'am.
ma'am, we
slide.
can
Yes,
see
ma'am,
it.
you can see your slide.
Okay. I think we stopped here, right?
Yes.
Yes.
Wow.
Yes, it's here.
All right. Okay, so I'm just going to switch off my video just to see if it will reduce interruption again. So I was talking about the substrate we need for re-entry, an area of block, a substrate, a unidirectional conduction block. I mean, We should not have chaos, even if somebody wants to try to help the heart to do what it's doing. We should not. Hello, can you hear me?
You can.
Yes, ma, we can hear
Okay,
you.
great, fine. So we should have a unidirectional block and then a path of slow conduction that allows sufficient delay in the conduction circulating wavefront to enable recovery of the refractory tissue proximal to the unidirectional block. Now, you don't need to stress yourself about this. What it's only saying is that there's a substrate, there's a block, and then there must the after one way block, there must also be something that helps the other part not to contract at the same time. So a part that is slowing down normal conduction from the normal, let's say, node, so that you don't have misfiring. So all these criteria are supposed to be kind of fulfilled for you to say, oh, this arrhythmia I'm having is from a re-entry pathway. AV nodal reentry, AV atrioventricular nodal reentry tachycardia is a common one we all want to run away from, okay? And I'll just try to make it simple. What happens in AV nodal reentrant tachycardia means that there is a fast pathway, okay? There's a fast pathway within the AV nodes, and there's also a slow pathway, okay? Now, normally, the fast pathway conducts impulses. If a premature beat finds the fast pathway still refractory, it will travel down. Excuse me. It will travel down the slow pathway and then loops back up the fast pathway, creating a reentry cycle within the AV node. Now, this is what we have said. AV node is like a substrate, okay? And then it wants to take over the SA node. So it must have two functions. It must have a fast pathway and a slow pathway. Normally, the fast pathway conducts impulses. The fast pathway is the one that collects impulse from the SA node. Okay, so what happens in AVNRT is that this fast pathway begins to fire. If a premature beat finds the fast pathway still refractory, it's supposed to have finished and then it's not doing so. So a premature beat says, oh, I can take over this thing, and then it takes over and travels down the slow pathway. Remember that the fast pathway is still excitable, but the slow pathway now goes on. And then these two loops now come back together to meet the fast pathway, creating like a reentry cycle inside the AV nodal reentrance. Now, what happens, what this gives us is that the AV node now begins to keep firing. It doesn't get back to the SA node. It keeps firing. It fires down to the ease of bundle to the Purkinje fiber. It takes over again as the cycle continues. Now, this sudden regular impulses creates a narrow complex tachycardia. So one of the things you will see in AVNRT is that the QRS is narrow and then it is fast. And this narrow complex tachycardia is between the rate of 150 to 250 beats per minute. So these are the things, these are the characteristics that help us to define the rhythm disorders we are looking at. The QRS is less than 120 milliseconds. Why? Because the conduction is via normal Purkinje fiber. The P waves are hidden, or they are embedded inside the QRS, or they appear as a pseudo RSR pattern. Call it RSR pattern, where you find a pseudo R in V1, a pseudo S wave in inferior leads. Which are the inferior leads? Quick recap. Do you know that the inferior leads? Inferior leads are 2, 3, and
2,
AVF.
3, and AVF.
Great. So you either find those pseudo R wave in V1 or pseudo S wave in 2, 3, and AVF with a tiny deflections after the QRS. Okay, examples is paroxysmal episodes of rapid heartbeat in young adults. You see them come in either under drug toxicity or excessive use of caffeine, or during exam period. You just see that kind of AV nodal rare. You see very fast rate. You see the QRS is narrow. You can't find any P wave. You are seeing pseudo V and S waves in inferior leads. So this tells me this is an AV nodal reentrant pattern. And this is quite different from atrioventricular reentrant tachycardia. The AV node is a problem with the AV node. The QRS is narrow. However, the AVRT is problems with an extra electrical pathway. We call them an accessory pathway. This one, there's an obvious anatomical. Remember I said it could be anatomical, reentry could either be anatomical or functional. But this one, there's an anatomical pathway, often called as accessory pathway, outside the AV node. Now, clinical example of this is with Parkinson-White syndrome. I'm sure we've all heard about it. What happens here? the impulse travels down the AV node and up to the accessory pathway. It travels down the normal AV node and then quickly branch off to the accessory pathway. Or it comes down to the AV node and it goes down, or it comes down to the accessory pathway first and then goes up to the AV node. So under AVRT, we have either the orthodromic or the antidromic. Now, this might sound too much for you as undergraduate, but it's important to have a basic understanding of it. What it means is that when the impulse travels through the AV node and then up to the accessory pathway, it's like mimicking the normal pathway, but it went off to the accessory pathway. And then this creates a re-entry cycle between the atrium and the ventricles. Now, the orthodromic pathway shows that I've come down the AV node and then I go off the accessory pathway, creating a narrow QRS complex. So it's like a narrow tachycardia. Those are often called supraventricular tachycardia, meaning that it has not occurred before, it has occurred shortly before the normal AV node. It comes down and then it branched off with. The other antidromic means that the impulse goes down the accessory pathway and then goes up the AV node. That has gone through like different routes before it comes down to the AV node. So that will produce a wide QRS complex. Okay, and it makes it look like a VT. It's really difficult to differentiate between this and a sustained VT. But most of the antidromic AVRT are not sustained. That means they don't last longer than 30 seconds. Now, ECG features will show you a short PR interval, very small, less than 3 boxes, a delta wave, which is like an upstroke. I often tell myself that delta wave tells you there's an accessory pathway somewhere, and then the QRS complexes are widened, especially if it is pre-excited. Now, this is just showing me different pathways. It's telling you what I've been trying to explain by my mouth. Okay, you have a natural input, it gets to the AV node, it goes through pathway 1, which is a faster conduction with a longer polarization phase. It goes down and take an accessory pathway and all that. So these are different examples that can happen before a complete circuit is made. And all these are shown on our ECG. Now, what do we see on the ECG? A visual guide to help us to understand what you find on the ECG. You look at your P wave. Your P wave are in AV nodal reentrance, they are hidden or retrograde. Hidden within the QRS, or you are seeing a small, tiny negative deflection when it's supposed to be positive. Then your QRS complexes are often narrow, less than 120 milliseconds, and then the PR interval is normal. For AV reentrant tachycardia, for the orthodromic pathway, the one that goes through the AV node first before it branches off to the accessory pathway, the QRS is also narrow. The P waves are often retrograde. You will see it immediately after the QRS complex. And then the PR interval is either short or normal. Unlike the Wolff-Parkinson-White, the one that is antidromic, the one that comes through the accessory pathway first before it goes up to the AV node, the QRS complex are usually wide. The P waves are neither here nor there. Sometimes it's hidden, sometimes it's retrograde, sometimes it might be normal, sometimes it might be flat, just there, variable. But the PR interval is always short with a delta wave. Okay, good. Now this is an example. AV nodal reentrance is this. You have normal P wave, normal PR interval, and then you have sometimes the P wave is retrograde, like you have here, or hidden. You have a normal QRS, you have a narrow QRS complex, or less than 3 boxes, and then you continue the pathway like that in a normal fashion. The AVRT, the one that is orthodromic, is also normal, is also narrow QRS complexes. But if you look at the Wolff-Parkinson-White syndrome, you can see that the QRS complexes are often wide, usually more than 3 big boxes, 1, 2, 3. This is going to the 4th, and the PR interval are very short. This is not even showing it well. Now, we are finished with disorders of the re-entry pathway. We've talked about impulse generation, automaticity, where I talked about bradycardia and all that. Now I want to talk about problems with conduction of impulses. There could either be a conduction delay or a block that will result in either bradyarrhythmias or tachyarrhythmias. For bradyarrhythmias, it occurs when the propagating impulses is blocked and it's followed by asystole or a slower escape rhythm. Asystole means that there is no contraction. It did not end up giving any proper excitability. Or tachyarrhythmias occurs when the delay and the block produce reentrant excitation. There's actually a block, but instead of it just going down, it now begins to fire. So many people try to take it over and cause a reentrant cycle. Various factors involving both active and passive properties determine the conduction, velocity, and propagation of an impulse. These factors include stimulating efficacy of propagating impulse, which is related to the amplitude and rate of rise of phase zero. Remember, I mentioned to us the action potential, those 4 phases. So all these stimulating factors, which a very common example is the electrolyte imbalance, will cause an increased excitability and allow these impulse conductions to go on. Now, this impulse conduction abnormality could either be a decremental conduction or an incremental conduction. Incremental conduction refers to the phenomenon whereby an impulse with a low safety factor loses activation effectiveness as it spreads antigroidally. And this property is most typically seen in the AV node. Okay? And that's what gives rise to a different pattern of AV blocks. Example of AV block abnormalities, we have first degree AV block. In this situation, impulse has been generated gradually in the P wave. Okay? So as generated impulse by itself in the P wave, you can see a normal P wave from the SA node, sorry, you can see your P wave. However, like I explained, it takes a longer time exactly for you to get to the AV node. So there's some of delay. There's still a normal conduction propagation from the SA node to the AV node, but it takes a longer time, which we'll find in our PR interval here. So the PR interval is long, is more than 5 boxes. Okay, if you look at here, we have 6, 7, 7.5 boxes. Okay, for our PR interval. So this is a first degree AV block. It just prolonged PR interval, but it will still excite the ventricle in a normal fashion. So you find it prolonged, but there is no drop at all. So that's your first degree AV block. The second degree AV block is 2 types. We have the Morbus type 1, the working back phenomenon, and then we have the Morbus type 2. Now, the Morbus type 2 comes with variable blocks. Now, let me go to Morbus type 1. The Morbus type 1 says that, well, I have a PR interval, okay? Your PR interval shows that, P wave is conducting normally, and then it is going to a QRS complexes. So your QRS complexes is increasingly prolonged, and then suddenly it drops, okay? PR interval can start 120, 140, 160, 180, and then suddenly you find a P without the corresponding QRS complexes. So you find like a pause, and then it goes on. So that is second degree AV block type 1. Second degree AV block type 2, I'm going to use it still in this place. Your PR interval are normal. You don't have any pre-warning that it's going to stop conducting. PR intervals are normal, okay? They are normal, and then it suddenly drops. So it can occur in different fashion, either a 2-to-1 block, like I have a 2 normal blocks, and then I suddenly have a block, or I have a 1-in-1, I have a 3-in-1 block. That is Morbus type 2. Then the third degree AV block tells me I do not have a regular PP interval. My PP interval seems to be regular. RR interval seems to be regular. My PP are doing it at their own pace. RR are also doing it at their own pace. They are both regular, but there is no relationship between my P waves and my QRS complexes. And usually the heart rate is very slow, often less than 40 and below. So that's the third degree AV block. There is no synchronicity between the atrium and the ventricles. This is an example of third degree AV block. If you count the heart rates here, 1, 2, 3, 4, 5, 6, 7, 8, about 300 divided by 8, it's less than 40, okay? And then you can see, well, it seems that I have a QRS. I have another QRS about the same pace. I have another QRS about the same rate. I have a P wave, though looks like it is inverted. I have a P wave at a regular pattern. This is another period, but they are not in any way. I cannot say after some phase I'll have a QRS following. That's what we call a complete AV desynchrony. Now, this is putting what I've said together. Your first degree AV block, where you have a prolonged PR interval, there is no block. The PR interval is just prolonged. The second degree Wickenbach phenomenon, you have a prolonged PR interval, increasingly prolonged, and then it drops. The second degree AV block, where it does not show me that it's not going to conduct. It keeps conducting normally, and then suddenly it drops. Okay, and then this is an example of second degree AV block 2-1, in which I have two P waves followed by one normal conduction. I have another two P waves followed by one normal conduction. It's doing it at a particular pattern. So in variable blocks already, you have a pattern. And then this is third degree AV block. You can see the heart rate is quite much less than 40. You have your regular P waves at some particular intervals, but there is no relationship. Like this now, I cannot find a P wave. The P wave came immediately after the QRS. And then this is another P wave. If you see the space between this and this, they're almost the same thing. But I now have P arrow. I have another P, about the same distance between this one and this one, another P. The same with QRS, but there's no relationship between the P and the QRS, meaning that when the atrium conducts, it's not able to connect properly with the ventricles. Ventricles are doing their own at a particular rate. The atrium are also contracting at a particular rate. Now, I have put this together to help us summarize what I've been talking about. We have a sinus rhythm. We have a nodal rhythm. I explained earlier, your nodal rhythm seems to be regular, but I cannot find a proper P wave, showing that, well, somewhere along the AV node is taking up the excitation normally, but it's not from the SA node. And then we have the heart blocks, okay, where you have more P's than QRS complexes. You can see P, no QRS, can P, Q, no PRS. So this will be an example of what kind of AV block. If you look at just this alone, what kind of AV block is this? I want responses from the house.
Third degree.
Great. So this will be an example of a third degree AV block. Now let's look at this. This is an atrial flutter. Okay. Now look at what I was trying to tell you about atrial premature complexes, atrial flutter. You see that it seems that I'm having a normal P wave. Okay, reentrant, a normal P wave. But this way, P waves are not followed by a normal QRS complexes. Okay, and this P wave have a phony pattern. We call it a sawtooth appearance, occurring at the same time. So this is a form of reentrant tachycardia. It has come in and is occurring before the ventricle. And there's some few escape rhythms comes here, and then it continues again. So there's a form of chaosity occurring in the atrium, and this often occurs in dilated cardiomyopathy. The atrium is so big that from the SA node to the Bachman bundle, a lot of excitability is going on. It keep re-entry, continue before it eventually gathers together and gets to the ventricles. Okay, so there's a lot of chaosity going on here. Okay, so this is atrial flutter. You have your RR intervals are fairly regular, but your atrium contractions are sawtooth appearance. This is totally different from atrial fibrillation. Now, it is important to mention that atrial fibrillation is one of the most common clinically occurring arrhythmias that we find in clinical setting, because we often find it in the elderly. We also often find it among people with dilated hearts or patients with heart failure. Okay, and how this one occurs is that when you check clinically, the patient has a fibrillating pulse rate, meaning that patient does not have a regular pulse rate. You put your hand on the pulse rate, it's irregular. Sometimes you want to differentiate between atrial fibrillation and ectopics. You have some patients to exercise. Okay, so when your patient exercises, we are able to see that the regularity of the pulse becomes better. Sometimes it gets slower. All right, so that becomes an ectopic beat. But if it is atrial fibrillation, when they exercise, it even becomes more irregular, and you cannot really predict what is happening. So we call it an irregular pulse. And then on ECG, the P wave is totally absent. As you see here, we can't really see. You can see that these sizes are totally different from these ones that are about the same size. These ones are chaotic, and they're of different shapes and different size. And then also your RR intervals are irregular. So in atrial fibrillation, you have absent P wave, no P wave preceding, no discernible P wave preceding every QRS complex. You have your RR interval is also irregular, and then you find your fibrillatory waves. Now look at this last one. This is your QRS complexes occurring in a chaotic fashion. The QRS complex, the ventricular contraction is fibrillating. So in this situation, I have a widened QRS complex. You do not even find any atrial contraction, just ventricular contraction, and it is a fast ventricular rate. Now, this is putting everything together to tell us about what we find with different conduction abnormality pathways. Okay, I'm going to leave us with this for those of us that wants to know more. In summary, it is important to know the mechanism of arrhythmias, and like I said, it is RATs: reentry, automaticity, and triggered activity. Under your reentry, we have different forms, okay? We have your AVNRT, you have your atrial flutters, you have your bundle branch block, you have your VT, you have your VF. Under automaticity, it's still SA node. We have enhanced automaticity
You owe me 100 naira now. You owe me 100 naira. We forgot to.
So you have an abnormal automaticity. So in that situation, you have examples of sinus tachycardia, sinus bradycardia. You have your ventricular tachycardia and all the rights. Then you have your triggered activity where you have problems with reentry pathway plus an abnormal pathway, usually channelopathies with Parkinson-White syndromes and all that. Now let's look at this if you can practice with them. Well, I put the answers there, really. There are images gotten from ECGs. This is just trying to help us recap, okay? Your rate is 60 to 100 is sinus. We have a P wave before every QRS complexes. PR interval is normal. Your QRS complex is also normal. Bradycardia, everything is normal, only that the heart rate is less than 60 beats per minute. Tachycardia, the heart rate is more than 100 beats per minute. Everything is normal. You have a P, QRS, T, normal QRS complex, T, but the rate, RR interval is more than 100. Now, this is a wandering pacemaker. This looks like a nodal, the first one I showed you of nodal reentry tachycardia, nodal junctional rhythm, sorry. The difference is that I have a P wave, okay? My P wave is not the same shape. I have another P wave, and my RR intervals are not really, they are not fast. In fact, most of the time they are 60 or less than 60. So this tells me a wandering pacemaker. So sometimes you look at this, you want to say it's normal, but you're like, not really normal. The heart rate is 60 or is less than 60. And then you notice that your P wave are not, they're occurring. Yes, they're like sinus occurring before every QRS, but not exactly the same shape. So call that a wandering atrial pacemaker. And what this tells you is that the pacemaker site has occurred from the SA node, but it has gone to other latent pacemakers within the atrium before they get to AV junction. And then it comes back to, do you remember that, why am I going fast? That is not from my original pacemaker. And then it goes back to the original pacemaker and all that. Okay? So the rhythm is irregular. The PR interval varies, but the heart rate is usually less than 100. Okay? This is sinus arrhythmias. This is an example of rhythm disorder in which, example of arrhythmias in which the heart rate accelerates on inspiration and slows on expiration, giving some form of irregular rhythm. And this is physiologically in young adults, adolescents, even in children. So on inspiration, it accelerates. On expiration, it slows down. So if you just take an ECG on inspiration, you see like a pulse. So when you have some form of normal space, this is usually on inspiration. On expiration, it takes a longer period, and then it continues again. So it is a sinus rhythm, but it is having variable longevity and all that. And this occurs during inspiration. During inspiration and expiration, all the beats are from the SA node. The longest PP or HARA interval exceeds the shortest such interval more than 0.12 seconds. And this is often following rhythm of breathing. So sinus arrhythmias is like the rhythm of breathing trying to follow the rhythm of the heartbeat. Okay, and this is normal in extremes of age, elderly or young adults. You find it prolonging during expiration and accelerates on inspiration and takes longer during expiration, giving some form of irregular rhythm, but it's still occurring from the external. So we should note that. Excuse me. Now, this is the sinus pulse. Sinus pulse tells me that, well, SNO starts and then it goes on for more than 3 seconds, like an arrest. And then it picks up again. So when you see only this, for example, patients on ICU, you see only this on the machine. So, this is an asystole because there's no conduction here at all. And then it suddenly picks up either on its own or through CPR or through some medication. Sometimes some of those patients are already on inotropics and all that. So you have a sinus pulse or a sinus arrest. Sometimes we see this in heartless, but usually it's less than 3 seconds pulse. So you have an electrical activity resumes when the SA node resets itself or can only do so by presence of a lower latent pacemaker and then begins to discharge again. But pulse time is not a multiple of the normal PP interval, meaning that if the normal PP interval is 2 and your pulse time is more than 4, it's more than 3 seconds, then you say that is most likely an arrest. And you're hoping that either it resets on its own or pharmacological means you're able to revive that heart. Now, this is an exit block. I've brought these examples because they look sinus. They are truly sinus, but somehow the pulse is a multiple of the PP interval in this sinus pulse. So you have this a drop beat times 2 of what we have here is what you have here. So that is obviously a sinoatrial exit block. Okay, where your kind of pulse is exactly times 2 of what it should be normally. Okay, we call that an exit block, and then it continues on its own again. Usually, you don't find this occurring regularly compared to this. It takes a long time, and then most likely a latent pacemaker takes over the action here. And then this one, the normal one suddenly remembers and continues. So this is an exit block, while that one is an arrest. Now, this is an example of atrial fibrillation. Okay, irregular RR interval. Irregular. This is sometimes we put a plain paper here to be sure if it is truly irregular or is following a particular pattern. This is atrial flutter for an AV block with 2 to 1 blocks. You can see this atrial flutter here. Regular PP, regular RR, and then your PP is subtle appearance. This is an asystole. No electrical impulses at all. Now, let's take this quiz. This first rhythm is what? What is this first rhythm? A.
Sinus rhythm.
Sinus rhythm. Great. So this is normal. This is normal. It's sinus rhythm. What is this rhythm B?
It's BP.
Sinus tachycardia.
Vita.
Beep.
Ventricular tachycardia.
It's BP.
Okay, so why is it ventricular fibrillation? Why is it ventricular fibrillation?
Because you have widened QRS complex.
Exactly. It's a widened QRS complex compared to a VTAC that you will find a narrow complex. Okay? And then your VTAC is actually faster. Okay? Your fibrillation can be fast. I mean, usually it's fast too, but you do not have a chaotic pattern like this. So this is a ventricular fibrillation. What about this?
First degree AB block. AB? No. There is a drop beat. There is a
third degree AV.
Second degree.
Okay. The person that says second degree, what kind of second degree? Is it Morbitz 1 or Morbitz 2?
It's Morbitz 1. There is prolongation of the interval before drop.
Oh, no. It can't be Morbitz 1. Okay, so this is actually not a fair, very good attempt, all of you. Well done. But this is not a fair rhythm stream to predict whether it's Morbitz 1 or Morbitz 2. But if you look at it, this is actually a third degree block. Remember I told you, it's extremely low heart rate. But because you don't have a very long rhythm to be able to tell you if the RR is equal. But you can see this is extremely less than 40 beats per minute. Another thing that will help you, these are PP, they are equal. Okay, these are PP intervals, seems to be equal. Same with your RR interval. Okay, so this is a third degree heavy block. Your KRS is absent. Now, if it is we all agree it is not a first degree heavy block, Abi. If it is, why is against a second degree heavy block? In second morbid 1, you need a prolonged PR before it drops. But this has only showed us one PR. Yes, it's prolonged, but we do not find it just drops. We cannot find any other one to show us it's prolonged before it drops. The same is, it can't be morbid 2 because we do not have any other one showing us a normal before it drops. You can see this dropped, this common, this dropped. So this is an example of a third degree vapor, right? What about D? What rhythm is D?
Is second degree heavy node.
Isolated,
Nodal reentrance or
premature,
what?
ventricular complex.
Very good. So look at this. There's an info here that will tell us what the rhythm. This is 2 times the RR interval. So something has happened here. There's an arrest. Okay? This is the RR interval. That's a clip. There's an arrest here. This is longer than, in fact, it's exactly 2 times this. What has happened here is what we call an escape beat. This is a ventricular premature complex because it is different to all this shape. Okay, we will not say it's a sinus pulse or a sinus arrest because this is actually showing us the ventricular depolarization, showing us the KRS complex. Okay, so what has happened here, okay, is a ventricular premature complex. But if I have it in a longer way, I can actually show either in the left-sided lead or a right-sided lead. This would likely be a left-sided lead, either a V5 or a V6. I can say this is a left bundle branch block. So your KRS complex is narrow, is widened. Cannot find a P wave. But this is obviously a VPC, just by looking at this short reading stream. Do we understand? Hello, yes, have I confused you? Yes, I've confused you. Okay, so don't worry. Yes, nobody will ask you at this level. But what I'm trying to say is that you have a 2 times RR interval and then in between these. So if this was a P wave, what would it have been? If this was a P wave and you see this 2 times PP, what would it have been?
It would have been a sinuatrial exit block.
Exactly. This is it. Would have been a sinuatrial exit block. Okay, but this time around they are showing us, okay, it's not me, I found this too online, okay, as test of reading disorder. But this is your KRS complex that's showing. The KRS complex is wider. Remember I told you that when you have AV nodal reentrance, AVRT, you find a wider KRS complex. But if you look at my criteria that I gave you about AVRT and AVNRT, this looks more like what? An AVRT. Because I mean this does not really fit into any one of them because your KRS complex is widened. Okay, and then you have your RR is quite wide. Okay, so this is a ventricular premature complex. Okay, there's not like a ventricular exit block. If not to that, so this is a ventricular exit block. And so that's why I told you that if we had it on the lateral side, I would have said this is the left bundle branch block. It's taking a longer time before that re-entry cycle to finish its course. Okay, so what about E? What is E?
It's flutter waves. Flutter waves.
Good.
Atrial flutter.
This is flutter. This is an atrial flutter. Okay. P like a sore throat is regular 1, 2, 3, and then you have a KRS 1, 2, 3. You have a KRS. You get RR interval is relatively regular, and yet you have a sore tooth appearance of the P, which is also regular. What about F?
Fibrillation.
For yourselves. Very good. So it's simple, Abby. Reading disorders is simple, right?
we may need some little help between AVRT and AVNRT.
So the best way to have a good hands-on is to try your hands on several readings. Go online. That's the good news about you guys at this stage. When we were training, there was nothing like Audible, but you have a lot of multiple resources that you can challenge yourself with.
Maybe you're at the end of the lecture, you should suggest some site for us.
Yeah.
you can suggest some site for us. Apart from life in the fast lane, maybe we need more.
Okay, so everybody knows about life in the fast lane, which is a good one. Some of them are paid services. I will send
No
that
problem. Even
through your
expert
link.
ones
Yes,
that are
sure.
cheaper. Yes.
No problem. I'll send that. I'll send some of those through your
Okay,
link. You
thank
can
you.
even
Let's continue.
yes. So now you look at why
those that are free should also be sent.
you said what?
Those that are for free should also be sent.
Sure. So we are almost done. Why do we need to monitor rhythm disorder? Sometimes your baseline ECG does not tell you what the rhythm disorder is, especially when your patient is symptomatic. So what you do is to look at other investigations to help you determine what exactly is going on here. Rhythm disorder is a whole ball game, is a whole subspecialty in cardiology. We talk about electrophysiology, rhythm specialist. Okay, so sometimes we need to employ more investigations to be able to know what exactly is going on. An example of that is an Holter monitoring that records ECG continuously for 24 to 48 hours. And then in that, you'll be able to give your patient a diary to be able to speak what exactly is going on each time they have those ectopic beats or each time they feel palpitations, and then you compare it in the Holter to see what exactly is going on. The other thing is mobile continuous outpatient cardiac telemetry. We don't have that for now in the country. However, there are a lot of telemedicine coming up, and that's something that mimics this that we can actually use. We have a loop recorder. Some people use the Holter, just do the like a 3-channel Holter instead of a 7-channel Holter. And then the difference is that it sends signals to the doctor. It's able to record when you have an issue and send signals through cellular technology to a monitoring station. It can be a combined one or to your doctor personally. Okay? Unlike Holter, that's only when you bring it back that we'll see what's going on. Then we have an event recorder, patient activated recorder. Some newer models have automatic arrhythmia detection software to store asymptomatic episodes. But this event recorder sees the patient is on that activate, I felt something, and then they press the button, okay? And the data is transmitted over the phone to a monitoring station. The same goes for an implantable loop recorder. Usually that one is for surgery, where patients' algorithm defined episodes stored in the device until interrogated. We can be there for 1 week, okay, until they come and check either at home or via the internet remotely. Now, we've known all this. We've been able to identify some very bad arrhythmias on ECG. What should be our response? We want to eliminate symptoms and improve abnormal hemodynamics, which can result from arrhythmias. The patient can be sweaty. As much as possible, the first thing is you yourself as a doctor should not panic. 2 is to try to make your patient as comfortable as possible. Try to correct any abnormality that is leading to that arrhythmias. Check for electrolyte imbalances and all that. Then prevent imminent death and hemodynamic compromise due to a life-threatening arrhythmia. Sometimes you have a VTAC, you have a VF. Okay, you look out for are there shockable rhythms? Are they manual defibrillators or an automated defibrillator that will easily help you to be able to discern if this is an arrhythmia to shock or not? They want to reduce possible risks other than the direct effect of the arrhythmia. Want to reduce risk of stroke, especially in patients with atrial fibrillation. Like I said, that's what we encounter commonly in a clinical setting. So in atrial fibrillation, you don't just want to correct the arrhythmias, you want to reduce the rate, and then you want to give anticoagulation to prevent other major adverse cardiovascular events. So this is an example of patients where you want to shock, VTAC and VF, okay? So now this negates what we said earlier on, VF and VTAC. Some VTACs looks like this, but this is faster than this. And some VF are a bit more chaotic than this, very tall waves and all that. So your machine, good news, the machines we have these days tells us which are shockable and not shockable readings. So you have your VTAC, you have your VF. This is an example of vascular premature complexes that I mentioned too. Usually in this, we don't have to shock. What we'll do is a beta blocker rate response therapy for them. The same with your atrial flutter and your atrial fibrillation. In addition to atrial fibrillation, in addition to beta blocker, you want to give anticoagulation. What are the other therapy for cardiac arrhythmias? Apart from electrotherapy, sometimes you do for with Parkinson-White syndrome, for example, you do what we call ablation therapy, where you do mapping. In the mapping means that you look at where the reentrant pathway is under electrophysiology, and then you're able to give an ablation therapy. Sometimes you could do surgery to remove those re-entering pathway. The anatomical re-entry pathway can be removed. Sometimes it might be because of a valvular problem, so you have a surgical intervention. And pharmacologic is a whole ballgame entirely, okay, to look at what are those medications you use to correct arrhythmias. And the caution here is that we leave that we don't allow you as maybe new doctors or associates to do that, except it's under supervision, because most of the anti-arrhythmic medications, they themselves are pro-arrhythmic when you begin to use them. So pharmacologic, the first one that is safe is to reduce the rates, okay? We do not try to correct rhythm abnormalities without proper supervision and without removing all the precipitants first. Thank you for listening. I'll take your questions.
Thank you very much, Ma, for the session.
That's beautiful.
So thank you very much. Thank you so much for the comprehensive and enlightening section. We have an additional information to what we had yesterday, and we are really grateful for your time, for the effort and dedication you have invested in making this lecture valuable. So we'd like to engage the audience. The floor is now open for questions, reflections, and if you have any things that you feel like you need clarification for, or you have a questions that you like to ask, please, you can come up and ask your question. Thank you.
Okay.
Thank you for the wonderful presentation.
Also, and put questions in the chat box. We'll go through the chat box and see if you have any question. For those that cannot come up, please, you can type your question in the chat box.
My question is if you can just show more light on this premature ventricular contraction. I am a little bit confused about it. Thank you.
Sorry, I didn't get that.
The
premature ventricular contraction.
Okay.
Okay, Ma, thank you. In addendum to that, how do we differentiate it from premature atrial contraction? Facts from PBCs. Thank you.
Okay, great. So for the questions of your preventricular contractions, let me see if I can quickly go back to first or second slide before the end. Premature ventricular contractions means that the abnormal rhythm you are going to see, what looks like abnormal is going to be the ventricular depolarization. That's your QRS complex. And that's what differentiates it from your premature atrial contractions. In premature atrial contractions, you have extra P waves that are not conducted, and they are of different shapes. This is different from ventricular contraction, which you have extra QRS complexes, often of different shapes. Usually they are wider, and they do not have a preceding QRS complex. So just like an escape bit, okay, I explained earlier, like a reentrant that just comes in to try to fill in the gap during repolarization phase, and then it just conducts send signals through the ventricles, and then it produces like that. Okay, so PVCs you find extra QRS complexes that are widened, abnormal shape, different shape from the normal QRS you've been seeing, like what we have here. While the atrial premature complexes often are escape bits that occur in the atrium. So what you find in those ones are different shape of P wave, abnormal P wave that does not have a QRS following it. Simple, irrespective of the rate. Anyway, both of them, they are irrespective of the wave. And then the next question, well, let me give myself the question because somebody might be thinking about it, is to now differentiate atrial premature complex from atrial flutter and atrial fibrillation. Okay, so now, like I said, atrial premature complex have extra P waves, abnormal shape, just comes along the line, just comes. Okay, but in atrial flutter, you have sawtooth appearance, plenty P waves that are about the same shape, but they are occurring in a sawtooth pattern without a corresponding QRS. You just find a QRS in a particular rate. R to R is normal, P to P is normal. P to P is the same shape, and they are regular. Unlike atrial fibrillation, it is fibrillating. You have multiple abnormal P waves, not just one along the line, multiple abnormal P waves, and then the RR interval is also irregular. I hope that answers your question. Hello?
Yes, thank you very much, Ma. That my question is regarding the okay, that may be a bit advanced. Regarding the WQWS, the pre-excitation syndrome. There is this young man, a student of Nigeria in India, that was having recurrent syncope, palpitations, chest pain. So he sent me his EKG actually, then thinking, okay, I'm in cardiology. He sent his EKG to me, that he did it not in hospital setting. There is this short interval with slowed upstroke, the classical delta waves, which I
Yeah.
told him to go and see a cardiology. They did an EP studies for him and localized the bundle of Kent.
Exactly.
He doesn't have money to go through the surgery, I think. Last as I thought. But one thing I want to highlight is that his EKG, the second one he did, there were AP. So sometimes Parkinson-West syndrome can degenerate to have atrial fibrillation, about 20 to 30% of them.
Sure.
Thank you, Ma.
Okay, so that's an addition. That's fine, well accepted. And usually what we do is to avoid electrolyte imbalances, but because they have found a substrate, until that substrate is ablated, we keep coming in and out of different forms of rhythm disorders. But I don't know what part of the country it's available. It's available in Lagos. It's available also in some centers.
He is in India recently. He's currently in India. He's 24, university student on scholarship there.
Oh, okay.
But
All right.
probably if he can't afford it there, but we wrote a letter for his parents that if they can intervene, he should get it there. If he couldn't, even he come back. If he studies, I know the centers are coming up now.
Yeah.
Lagos, Port Harcourt,
Yes.
and Abuja.
Yes. Abuja, even in Enugu, I think. Yeah. All right.
Okay, Ma, there's a question in the chat box. In the case of people on pacemakers who go into cardiac arrest, will it reflect too on top of the resuscitative drug effects?
Will it? I don't get. Will what?
The question, will it reflect too on top of the resuscitative drug effects? In case of people on pacemaker who go into cardiac arrest.
Okay, so most of the time, for those on pacemaker, they don't just suddenly go into cardiac arrest. So pacemaker is supposed to be interrogated, meaning that you're supposed to, there are times where you have there are so many times, talk about the impedance, you talk about the pacemaker responses. So ideally, those pacemakers should be reset to fit into your daily activity. And for them to be on pacemaker, they don't suddenly go into arrest except you have a pacemaker failure. So that pacemaker did not caption. So before you begin to do any intervention, if it is very fast, a cardiac arrest means that the heart did not generate an impulse. And so also the pacemaker also could not do anything, right? Let's understand that. So the patient comes in with a sudden cessation of cardiac activity, or the patient is on the ward and was noticed to have had a sudden cessation. So the first thing is you do a CPR, you try to revive that first, and then you bring in the pacemaker can have an ICD on top of it. So those kind of patients, is your hemodynamic instability that you address first, and those ones can come to medications, and your medications will follow the hemodynamic stability of the patient. Either it has nothing to do with pacemaker now, because your pacemakers are failed. Do you understand? So it does not interact with the fact that the patient has a pacemaker. However, if the patient came in with abnormal rhythm despite a pacemaker, it's not cardiac arrest. Maybe you didn't frame the question. It's not a cardiac arrest now. Patient comes in with a ventricular tachycardia or comes at a very slow rate and is symptomatic. We still address the symptom they present with, and reset the pacemaker. Did that answer your question?
I hope it answered the question for the person that brings up the question. Okay, so there's another question. There was another question on the chat box, which goes us, what determines if an atrial fibrillation patient is a candidate for anticoagulation?
Oh, beautiful. So that's a good question. Now, we have some guidelines, we have some criteria, okay, that tells us that this patient needs anticoagulation or not. Almost all patients with atrial fibrillation will require an anticoagulation. However, we look at what we call the Hasbled score to determine a patient that is at risk for bleeding. Okay, so often there's what we call let me just put it in private. There's what we call chart score, and a refined one now is the chart 2 score. Okay, chart 2 score, which is guidelines that these are criteria put together to determine, okay, whether a patient needs to be on anticoagulant to prevent stroke occurring from atrial fibrillation. Okay, but for patients that have atrial fibrillation from valvular disease, they must be on anticoagulation. Okay, non-valvular atrial fibrillation. I mean, I have atrial fibrillation from heart failure. I have atrial fibrillation from any other cause that's not a valvular cause. We then now want to use, do I need to give anticoagulation or not? If you put these calls together, congestive heart failure, hypertension, diabetes, previous stroke in the past, or TIA, age, and sex, we put them together and it's more than a score of 1, that patient must be on anticoagulation. 0 to 1, you might not give. 0 or less than 1, you will not give. You give antiplatelet instead. However, if patient is elderly and we want to weigh the risk of bleeding versus risk of anticoagulation, you now do what we call the Hasbled score. Hasbled score will give us to predict the risk of patient likelihood to bleed. Okay, and if your Hasbled score is more than 9 or so, remember it, you will not give anticoagulation in those patients. Okay, does that answer your question?
Yes, ma'am.
All right, Ma, thank you. There's another question. What's the difference between atrial flutter and fibrillation? I need clarification.
Okay. Atrial flutter means that is a flutter wave. Okay, your P waves are regular. They are sawtooth appearance. The RR interval is also regular. But fibrillation, they are fibrillatory waves. That means your P waves are not the same shape all through, and your RR intervals are irregular. Simple.
Okay. Someone asked, can you please go over the types of AV blocks and their distinctions? Thank you, Ma.
Wow. Okay, that's like taking the section on conduction problems again. Okay, so AV blocks. First degree AV block, we have your prolonged PR interval. Okay, your PR interval is more than 5 small boxes, 200 milliseconds, but it is able to it's still being followed by a QRS complex. So every P is followed by a QRS complex. Okay, but the PR is prolonged. That's your first degree AV block. Okay, your second degree AV block is divided into 2. You have second degree Morbis type 1, which is also known as the Wickenbach phenomenon. If you check YouTube's, any of the YouTube channels and put ECG in a funny way or conduction blocks in a funny way, they'll describe it in different funny way. I've seen one that talks about the husband and the wife, so maybe I use that. We talk about your second degree AV block. The PR interval is constant. Morbis type 1 is constant. Sorry, Morbis type 1, the PR interval prolongs gradually, and then it stops. And then there's no QRS after a prolonged PR interval. So, but your PR interval is prolonged gradually. So you have a first phase, okay, it is 5 boxes, 200 milliseconds, and then it's followed by a QRS complex. The next one is 240 milliseconds. The next one is 260 milliseconds. And then the next one, you find it prolonged and there's even no QRS following it. So that's the Morbis second degree Morbitz 1, the Wakenbach phenomenon. Okay. The second one, Morbitz type 2, second degree type 2, is your PR is constant. You don't even know that anything is going to happen. It is not prolonged though, it's normal. Okay, it is normal, it is not prolonged, and it is constant. And then suddenly your PR is not followed by a KRS complex. That's Morbitz type 2. Third degree AV block is the PP. There's P occurring at the same interval. There's R occurring at the same interval. However, there's no relationship between the P waves and the R waves. And it's often extreme bradycardia. That's the third degree AV block. Okay, now let me liken it to a funny way. We talk about a couple, husband and wife. The first degree AV block says, oh, this man is always coming late. The woman says, my husband is always coming late, but he knows that he will come anyway, but it's always coming late. That's the first degree AV block. PR interval is prolonged. 240 milliseconds, he's supposed to come home at 200 at 5 p.m. He will always come home at 6 p.m. It's prolonged all through. That's first degree AV block. Second degree AV block, Wakenbach type 1 shows that this man is supposed to come home at 6 p.m. Today, he comes at 7 p.m. Tomorrow, he will come at a later time, 7:30 p.m. Day after tomorrow, he comes at 8 p.m. So the QRS complex is coming, but it's at a longer period. That's Wakenbach phenomenon. Second degree type 1. It will definitely come. But I can no longer say it's coming late at 7 p.m. It will come 7:30, the day after tomorrow will come 8 p.m. Like that. That's second degree type 1. Second degree type 2 is worse. It comes normally at a normal time, and then suddenly it doesn't come. That the PR interval is normal, and suddenly there's a drop. There's no QRS following a PR. And third degree, well, whether it comes or not, I will do my own. So the husband comes home at a particular time, the wife is at home at a particular time, but there is no relationship. Do we understand? Does that answer your question?
Yes.
Fight. Thank you, Ma. There is another question. Does inotropics lead to more arrhythmia, and why? Does it mean inotropes are not effective?
Okay, so inotropes helps contractility. Okay? Inotropes are effective. However, some of them are toxic to the cardiac myocytes. Okay, so I'm sure the person asking this question must have experienced the fact that some inotrope like cardiac glycosides, digoxin, and dopamine, and all that have been said, or they have been noticed that it has caused arrhythmias in some patients, because you use those drugs to help contractility in a way of helping a weak heart to contract more. Okay, to contract more, to do depolarization at a particular rate. If it's a disease myocardium, it might likely lead to arrhythmias. So it doesn't mean that they are not productive, they are not supportive, they are good. But sometimes it could be counterproductive because over a long period of time, they themselves become cardiotoxic. So initially, you use inotrope to help contractility, to stimulate output, to raise the BP, and all that they are contracting. They are getting a good effect acutely. If it do not win out, if that patient does not have a sustained good effect and continue to flog the heart with inotrope, sometimes it might. And the mechanism of causing it might just be electrolyte imbalances. Okay, they do not follow a particular pathway. Just be electrolyte imbalance, or just have repeated recurrent ectopic beats that become sustained. Remember that once an ectopic beat, they look like they're causing more arrhythmias. No, they are good, but they are good as short-term use. Okay, and remember that inotropes are different from chronotropes. Chronotropes will reduce your rate. They will help to control the while inotropes are helping the force of contractility to improve your cardiac output. Okay.
Okay, there's another question. When do you decide to use warfarin instead of direct oral anticoagulants in atrial fibrillation, and why?
Oh, great. Warfarin-dependent anticoagulants is, as of today, as at today, your warfarin is best used for every valvular heart disease. Any patient with valvular heart disease with atrial fibrillation, you use warfarin. The direct acting oral anticoagulants, the NOACs, that are often used for non-valvular AF. Okay, they are often used for non-valvular AF. And so that is when you use direct acting oral anticoagulants. But if there's an AFib and there's a background valvular disease, please stay with your warfarin. They've not tested those other ones in, I think one of them have been tested, but the result is not yet out. All right.
Thank you so much, Ma.
Okay.
Thank you so much. I think we have come to the end of today's section. And okay. Yahya, are you there?
I'm here. What?
No.
I think there is one question written in the chat box, please, about you can read it. The about this thing.
Come on.
AVRT and AVNETR.
We can't hear you.
I said there is one message in the chat box that they said, please, my question about AVRT and AVNRT.
Okay, I can see that. I'm going through the chat box now. All right, so talking about differences, I'll just go through it again. I think I have a table that gives us a summary quickly. Talking about the difference between AV nodal reentrant tachycardia and AV reentrant tachycardia. AV nodal shows that all the problem is coming from the AV node. They are both examples of reentry tachycardia. Okay, for AV nodal reentry tachycardia, it shows that, it shows that you have a normal fast pathways. Okay, and then you have a reentry going through the AV node. And what results on ECG is a very fast heart rate, more than 150 to 250. The complex is narrow. Let me just give you the table. This is it. So your AVRT is either orthodromic or antidromic. But if this is confusing, just know that for your AVNRT, your KRS complex is narrow. For AVRT, you have most of the time a widening QRS. If you have a narrow QRS, then your P wave will come after the QRS. Okay, and your PR interval for AV nodal is normal. Okay, for AVRT, the common one of AVRT is this Wolff Parkinson one, is one that has a substrate and antidromic, in which your electrical impulses goes through the accessory pathway first and then goes up to the AV node. And so that makes the KRS complex to be wide, and that makes the PR interval to be short with a delta wave. But it is problem with the AV node. The reentry is occurring within the AV node. The P wave is usually hidden, or retrograde is hidden within that KRS complex, and your PR interval is normal, your KRS complex is narrow. Does that explain it? If you have the slide, we can go through how we get to this place, trying to explain where the extra electrical pathway is from. Okay, but if you want a quick glance, this is what differentiates them on ECG.
Thank you very much, Ma. We're expecting the slide.
Thank you so much,
Ma, for revision.
All right.
Please, I just want to make a brief comment. I'm very sorry. Please, those that are asking questions related to therapy, we should remember the purpose of this webinar is to learn the tracings. Let the tracings be of sense to us. So please, our questions should be strictly and directed to the ECG tracings. Thank you.
Yeah. That's nice. Thank you so much. I really appreciate.
All right. Thank you so much for that. Does anyone?
All right. Thank you for having me. I'm glad I'm able to break it down. Okay. Keep learning.
We hope the slide will be shared to us now.
Yes, I think the slide would be made available for everyone.
All right. Thank you very much, ma. Nice meeting you. Thank you, the organizers. Have a great evening.
All right. You are welcome. You are welcome.
Okay, am I permitted to leave now?
Yes, ma.
No.
Yes, ma.
All right. Thank
Thank you
you.
so much for the insightful section, ma. Thank you so much.
All right.
Really. Thank you.
You're welcome.
Have a nice day.
Yeah.
Kiamata